Hello everyone, welcome to this new video. In this video, series of videos, we will explain some bases, obstetrics and gynecology, internal medicine, surgery and pediatrics. Before I explain them, I want to explain to you how you can get these bases for free. They are the most updated bases for Krok questions, and they will help you a lot in studying subject wise, so only subjects if you want to start with this. So you go to krokology.com, which is the website I recommend for studying for Krok 2, and you go to English, medicine, then Krok 2, then go to the, after you make of course a free account, and then you go to the subject section again, and then you can choose the subject you want to practice. So for example, obstetrics and gynecology next, and then you can practice about 400 only gynecology questions, most updated to the latest year of booklets, like previous bases hadn't this feature. So make sure to take advantage of this feature, and let's start the explanation. This video we will solve some questions in internal medicine base. Here we have a 52-year-old patient who has been suffering from angina pectoris for 2 weeks, has more and more frequent pain attacks in the area behind his sternum, and his need for nitroglycerin increased. Objectively, the condition is of moderate severity, skin is pale, heart sounds are weakened, and the heart rate is 84 per minute. ECG shows no sign of myocardial damage. What is the most likely diagnosis? So angina pectoris is very important for Krok 2, because it's like important as well in the real life and clinically. So they try to bring a lot of questions about it and cardiology in general. So you need to understand it from all all types of them, of the angina pectoris, and it's how to differentiate it from myocardial infarction. So first of all, you see in the options a lot of angina pectoris, first time, progressive and stable, and myocardial infarction, variant angina pectoris. Let's see about first of all, stable angina pectoris, how it's defined. First of all, angina pectoris and myocardial infarction are all diseases because of the coronary artery. Okay, this artery here that supplies the heart with blood, it's a problem here that's causing the disease. The difference is that in angina pectoris we have partial obstruction, as you can see here. There is some amount of blood that can pass through and supply the heart, but it's very less than the normal open artery, as this one on the left, and thus see here, this area here, it gets blood and it's very nice, but this area here on the right, it has ischemia, and as a result of this there will be pain. In myocardial infarction there is, as you can see here, complete obstruction, and because of this complete obstruction, the area will have not ischemia, only infarction, which is like necrosis of the cardiac tissue, right, because of complete occlusion. As a result of this, all of them will have chest pain, okay, whether angina pectoris or myocardial infarction. Chest pain, retrosternal, can be radiating to the left jaw, to the left arm, left shoulder, and so on. So the type of the pain cannot give you the answer, but the intensity and the character of the pain can make you make it easier to differentiate. So all of them will have this retrosternal pain radiating to the left shoulder, arm, neck, or jaw. So what is the difference? Is that here we have also about different types of angina pectoris, stable or unstable. Let's talk about them. Stable angina pectoris will have, like here as an example, it occurs in a patient who is already diagnosed with angina pectoris, and he has it for months or for years, and he lives with it, and he knows that he knows when the pain will arise, on which type of physical activity, on how much effort this pain can arise, and he knows how to relieve it, to relieve angina pectoris. It can be by rest or by nitroglycerin, which is these pills under the tongue can dilate the vessels and decrease the work on the heart. So meaning that the patient knows the type of physical activity and everything about this. In contrast to the unstable angina pectoris, this is a new type. The patient will have stable angina pectoris, and then suddenly he will have this new type of attack that is more intense and takes more time and doesn't decrease with rest or nitroglycerin. It needs more pills of nitroglycerin to stop. It doesn't decrease with rest for 10 minutes, maybe for more, and so on, last longer, less responsive to medication. It occurs with less physical activity than what he used to, and then it means that it's progressing. The artery is more obstructing, right? And because of this, less blood going to the heart and more symptoms and more yes. So back to the question, we see that the patient was suffering from angina pectoris for some time, and he has more and more frequent pains and attacks, and his need for nitroglycerin is increased. He was taking one pill, he's now taking more and more, and so it's unstable, as you can see. Another name for unstable is called progressive, like it's progressing from stable to unstable. And ECG shows no signs of myocardial damage, so no signs of infarction. It means that it's not myocardial infarction. Myocardial infarction will not respond at all to rest on nitroglycerin. Okay, either non-STEMI or STEMI. These types can be explained later, but they don't respond at all the myocardial infarction. Unlike angina pectoris, it can be unstable, can respond, but it's less responsive. It takes more pills to nitroglycerin. So that's why it's not myocardial infarction. Yes, so it's progressive angina pectoris. Next question we have about a 7-year-old child complains of cramping pain occurring after mental exercise, cold drinks, and eating ice cream. We diagnose biliary dyskinesia of hypertensive type. What group of drugs should be prescribed? Biliary dyskinesia is disorder of the motility of the gallbladder. The gallbladder sits under the liver, as you know, and it contracts every time there is food to excrete the bile. The bile is important for digestion of fats, for example. When there is disorder of this contraction, either if it contracts too much or it contracts not at all or like very few, then we call it biliary dyskinesia. Hyperkinetic, it means too much. Hyperkinetic, it means not a lot. Irregular diet can be as a reason. Here in the question, they tell us that it's hypertensive type, so it's the type that is contracting too much, right? For this, we need to give something that slows down and relaxes the gallbladder, and this should be choleretics and antispasmodics, especially antispasmodics. Antispasmodic will relieve the spasm of this gallbladder. It's spasming a lot and hyperkinetic, so it relaxes the gallbladder, and this is what we need, right? On contrast to hypokinetic dyskinesia, which needs cholecystokinetics, right? Which fast increase the contractions rather than slowing it down. So this antispasmodic for hyperkinetic type. and cholekinetics for hypokinetic type, right? You need also in some questions to differentiate biliary dyskinesia from cholecystitis, which is inflammation of gallbladder. In biliary dyskinesia, it's just motility problem. There is no inflammation of the gallbladder, and there is no fever, for example, and there is no nausea and vomiting and Murphy sign, which is all cholecystitis signs. And of course needs cholecystectomy and antibiotics, removal of gallbladder, antibiotics. Next, we have a patient with the following symptoms. He has diffuse enlargement of the thyroid gland, exophthalmos, weight loss up to 4 kilos within the 2 months, and excessive sweating. Heart rate is 105 and 5 per minute. Stool is normal, but therapy is advisable in this case. Diffuse enlargement of thyroid gland with exophthalmos and weight loss and excessive sweating, it's a sign of Graves' disease or diffuse toxic goiter. This disease is disease of the thyroid gland, the gland present in the neck, and when it increases in size and releases a lot of the thyroid hormone due to autoimmune etiology, then it's called diffuse toxic goiter. From its name, it's diffuse, so we have diffuse enlargement of this gland. It will be diffusely enlarged. It's toxic, so it's releasing a lot of thyroid hormones, and it's goiter is causing enlargement of the thyroid gland. So diffuse goiter, it's the first sign of this disease, diffuse painless enlargement of the thyroid gland. The second sign is thyrotoxicosis. Thyrotoxicosis means we have exophthalmos, the bulging eyes, like this woman here. Second thing, weight loss, because a lot of thyroid hormones increase metabolic rate and leading to fast burn of the calories and so on, and with increased appetite, so weight loss, and everything will be, increased thyroid hormones will be faster. You see here this picture showing the signs of hyperthyroidism. So this patient we have has diffuse toxic goiter. What is the treatment? There are 3 lines of treatment. Antithyroid drugs that will block the effects of the thyroid hormones, like mercazolil, right? And this was one question. And also to slow down the heart rate, which is fast in case of hyperthyroidism, we give beta blockers such as propranolol. They decrease the heart rate. This is the option 1. In case of more severe disease, more severe degrees of the diffuse toxic goiter, for example, the weight loss reaches more than 12 kilos, there is instead of just tachycardia, there is arrhythmias in the heart, there is atrial fibrillation, there is a risk of cancer. This thyroid gland enlargement can go to cancer. Then we choose thyroidectomy, removal of the thyroid gland. Radioactive iodine can be given in moderate cases in older people because radioactive iodine can increase the risk of cancer. Okay, so back to the question, we should give mercazolil. Heart rate here is 105 per minute, the normal 60 to 100. So propranolol, you will see in other questions, the heart rate will be like 160, 150, and they will not mention mercazolil as one of the options, and they will tell you what you should do, what you should prescribe for heart rate. I think that was the question that you should choose propranolol for. So next question we have is a 42-year-old man has undergone gastric analysis, and free hydrochloric acid is absent in all phases. On endoscopy, gastric mucosa loss, gastric folds are smoothed out. On microscopy, glands atrophy with intestinal metaplasia. What disease can be characterized by such presentations? We have here gastritis, inflammation of the stomach, and we have 3 types of gastritis: gastritis A, B, and C. Most commonly in the questions you will see A or B. A is called atrophic gastritis. A, atrophic. It causes atrophy of the glands in the stomach, especially the glands that contain parietal cells. And these parietal cells, guys, produce acid. right? So when they tell you the question that there is hydrochloric acid is absent, which is the acid of the stomach, and it's absent, then it means there is problem with the parietal cells, one of the characteristic of gastritis type A. If you find this hard to memorize, then type A, atrophy. Whenever you see in the question atrophy, it's gastritis type A. Gastritis type B is more common. It's because of infection by Helicobacter pylori, and it can cause gastritis. So this is type B gastritis, and it's can cause ulcer later. Okay, so this is type A. Next, we have a 41-year-old patient with Addison's disease. He had influenza. After that, he developed adenomia, depression, nausea, and vomiting and diarrhea, and hypoglycemia. Blood pressure 75/50. Blood test decreased content of corticosterone, hydrocortisone, all corticosteroids at derivatives. What condition has developed in this patient? So first of all, we need to know what is Addison's disease. Addison's disease is one disease in endocrinology that is about the adrenal gland. This is the adrenal gland, sits above the kidney, and it releases many important hormones, as you know, such as cortisol, such as aldosterone. And the problem happens when there is infection of this gland or autoimmune damage. Then we can have acute failure of this gland, or chronic infection, chronic failure of this gland. Acute is called adrenal crisis, chronic is called Addison's disease, right? So what we had here in this patient is Addison's disease. He had Addison's disease, chronic autoimmune or autoimmune inflammation of the adrenal gland. Chronically, he had low function of this gland, but this chronic disease can turn into acute when there is acute stress on this gland. Okay, this gland is already chronically inflamed, chronically has a problem, and if there is on top of this acute stressor, such as surgery, injury, illness like flu or influenza, right? This is a stress on the body. Stress on the body needs more cortisol, right? This will turn the Addison's disease into acute failure of the gland, right? So what happened here is that Addison's disease plus influenza, acute stressor, then Addison's disease will turn into acute adrenal gland failure, evidenced by decreased cortisol levels, which are the products of the adrenal gland, decreased blood pressure. All of these are acute manifestations. So what happened here is acute adrenal gland insufficiency. Adrenal insufficiency, important topic for Krok, both acute and chronic adrenal insufficiency, so make sure you know about it and different types. Next, we have a 15-year-old patient, suffers from headache, nasal hemorrhages, sense of lower extremity coldness, muscle of the shoulder are developed, lower extremities are hypertrophied, pulsation of the pedal and femoral arteries is sharply dampened, blood pressure is 150/90, 90/60 in the legs. Systolic murmur can be auscultated above carotid arteries. What is the diagnosis? So here, this is one of the easy questions. If you understand the idea is very simple. We have a disease called aortic coarctation. It's a narrowed aorta, right? As you can see here, this is the area which is narrowed. As a result of this, more blood will go up, less blood will go down. Because of this narrowed area, less blood can go in this way, so all the blood will go up. As a result of this, we will have more blood pressure in the upper side of the body. They will tell you we have the muscles of the shoulder are developed because they receive more blood. Lower extremities muscles are hypertrophied. They are less in size because they receive less blood. The blood pressure in the upper side of the body, like here, the normal is 150 on the arm, but in the legs it's 90. So all of these, when you see high blood pressure up, low blood pressure down, it's aorta coarctation, right? Here you can see some information about it, but it's very simple idea. A 30-year-old patient was hospitalized in the intensive care unit with a diagnosis of multiple bee stings. Skin is pale and covered with cold sweat. Pulse can be palpated only in the carotid arteries and 110. Breath rate is 24. What drug must be administered immediately? So this patient is in a state of emergency. He's pale. He is like covered with sweat. He has pulse only palpated on carotid arteries, and this happened all after multiple bee stings. So multiple bee stings probably induced or stimulated allergic reaction in this patient called anaphylaxis, right? It can be by these things, bee stings, snake biting medications, food allergies, and will make all the emergency like manifestations: shock, bronchospasm, angioedema looks like this, urticaria looks like this, skin condition, and of course the dangerous are the respiratory system and the circulatory system, causing shock and maybe coma. So we need to reduce this allergy as fast as possible and also support the blood pressure. What we should give is in an acute condition, like when the patient is on the street or at home or something, he has these injections with him, intramuscular epinephrine injected intramuscularly, as you can see, and it can work. But in case there is more acute condition, and it's in case of no response, or in case this patient is at hospital, then he can be admitted into an intensive care unit and intravenous epinephrine can be given. So in this patient, we see that he is in the intensive care unit already with this diagnosis. So this gives us the opportunity to give him adrenaline intravenously. Intramuscularly can be administered at home. So this, in case intensive care unit, he should have it intravenously. Next question: a 24-year-old patient complains of gaining body mass and increased appetite, objectively built of hypersthenic type, like overweight, and he is body mass index of 33. Waist circumference is 100 centimeters. Waist to hip circumference is 0.95. What is the diagnosis? Here we have a question about obesity. We have 4 types of obesity, but there are more types, but these are the types you need to know for Krok. As you can see in the question, let's take it bit by bit. We see some options saying alimentary obesity, some options say Cushing obesity, elementary Cushing. So let's see if it's alimentary first or Cushing. Elementary is just because obesity because of the diet, it's familiar to us. It's due to diet that's unbalanced, increased caloric intake with carbohydrates, fats, and so on. Dysplastic, it's because of Cushing syndrome, one syndrome because of endocrine disease, because of a lot of cortisol. Cortisol can increase the fats on some areas in the body, like upper back and so on, but it has a reason, not because of the diet, because of increased cortisol. So in this case, we see no signs of this. We see that he has this because of increased appetite, because of his diet. So this is not Cushing. This is alimentary obesity, right? Due to diet, increased appetite. So that we have it. Then we go to the next thing in this question. Is it stage 1, stage 2, or stage 3? To define the stages of obesity, we have this nice table. It's very easy. A normal weight we classify normal weight, overweight based on the body mass index. It's the weight over the height to the power of 2, so height multiplied by height. In this patient, they gave us that the body mass index is 33. Okay, so it's 33. 33 is class 1 obesity. Normal weight is between 18 to 25. Overweight 25 to 30. Class 1 obesity 30 to 35. So this patient has class 1 obesity. So based on this, we can say that the answer is A, and we don't need to solve further because these are not true. But we see what is the difference between android and gynoid type of obesity. We have here type of obesity according to the fat distribution. If there is central obesity, it means that more fat is above the waist. Peripheral obesity, it's more fat or more weight below the waist, right? Hips and so on. Central obesity is more in men. And to know about this, you need to calculate the waist to hip ratio. So the circumference of the waist and circumference of the hip, and then divide them, and then you have a ratio. In central obesity or abdominal or apple or android type of obesity, then we have waist to hip ratio more than 0.9, meaning the waist is more than the hip. Then here in the question we have it as 0.95. So it means that we have here abdominal type of obesity or android or apple. Then this is android obesity rather than gynoid. Right, so the answer is A. Next we have a 57-year-old woman complains of having sensation of esophageal compression, palpitation, and breathing difficulties when eating solid food, vomiting with a full mouth, wet pillow sign, body temperature is increased, weight, X-ray revealed considerable dilation of esophagus and constriction at the cardial part. What is the diagnosis? This sentence here is the important thing in this question. When we have dilation of the esophagus with its constriction at the distal part, all right, this means we have what's called esophageal achalasia, right? It's a condition in which there is the lower sphincter of the esophagus is constricting. This sphincter here is constricting. As a result of this, the esophagus will dilate and its last part will be constricted. It makes this appearance on X-ray. So because of this, it's called esophageal achalasia. Of course, this can produce problems with digestion, with swallowing. There will be dysphagia, difficulty swallowing, solid and liquid food. It may look like esophageal cancer, but in esophageal cancer questions, we will have weight loss. And on X-ray, they tell you there is filling defect, meaning that the area of the cancer will not be filled by contrast on X-ray. So on this, because of this, this is achalasia cardia. Esophageal diverticulum, they will tell you the question, we have an outpouching on X-ray like this. Last question we have today is a 45-year-old patient has been suffering from essential hypertension for 10 years. After death, he suddenly developed sharp headache and recurrent vomiting, pronounced meningeal symptoms, blood pressure is 180 over 110, was hospitalized in neurology. What additional tests should be prescribed? So, also important question, repeated a lot. We have hypertension history, and then meningeal symptoms, and then some neurological meningeal symptoms mean neurological symptoms. So what happened here is bleeding inside the meningeal layers. It's called subarachnoid hemorrhage. We have first some dilation of the artery called aneurysm, and then this aneurysm can rupture, causing bleeding into the subarachnoid space. Risk factors are hypertension. For example, the patient will have increased blood pressure, like as a disease for 10 years. And because of this blood pressure, at one time, this high pressure will cause like a rupture of this weak spot called aneurysm, leading to bleeding into the subarachnoid space, right? Especially here after hot bath. They tell you after hot bath, the blood vessels can dilate, right? And this dilation can also further the rupture the aneurysm. Anyway, it's not important. But meningeal symptoms, back to the point about subarachnoid space. This space is important because, as you can see in this picture, the blood is here, not inside the brain tissue, but around it. It's called subarachnoid space. It's the space between the arachnoid matter and pia matter. And in this space, we have the cerebrospinal fluid. This fluid, which is the fluid that through it it runs between the spine and the brain, right? In this space we have this space called subarachnoid space, and inside it we have cerebrospinal fluid. In this space we have the bleeding. Okay, that's why it's called subarachnoid hemorrhage. Okay, so and produce this hemorrhage produce meningeal symptoms because we have bleeding into the meninges, which is the layers around the brain. So symptoms such as neck stiffness, photophobia, Brudzinski and Kernick signs, which are specific symptoms we will see in pediatric explanation of the base. So make sure to see that video. So what is the diagnosis? The question is asking about the diagnosis. The diagnosis is to take a sample of this cerebrospinal fluid, which has the bleeding inside it. Take a sample of it and study it. If we see blood, then it means that we have subarachnoid hemorrhage. If not, then it's something else, right? So in this procedure is called lumbar puncture. Lumbar puncture, we will find bloody CSF, bloody liquor in some questions, high erythrocytes. And this is, tells you that we have subarachnoid hemorrhage. So this was internal medicine piece. And as last, I want to announce about our course with Krokology that includes the explanation of Krok 2 booklets, the same way we explain these bases. So if you like these videos, make sure to check our course, which starts from January next year. And for more videos, make sure to follow this channel.